rounds from University of Colorado Hospital and University of Colorado Anschutz Medical Campus. Our presentation today is on hospice decision-making in older Black adults. If you would please put your questions or your comments in the chat, I will read those to the group for Dr. Tate to address after her talk. And this presentation is also being recorded. It'll be available through the Center for Bioethics and Humanities here at Anschutz Medical Campus, and that link will be posted or you can access it on their website. Before I introduce Dr. Tate, I do want to mention that our next Ethics Grand Rounds will be Thursday, May the 9th, and it will be with Dr. Matt DeCamp and others speaking on ethical issues pertaining to artificial intelligence. Now it's my honor to introduce our speaker today. Dr. Channing Tate is assistant professor at the University of Colorado in general internal medicine and geriatric medicine. And she, again, is going to be presenting to us on hospice decision-making in older Black adults. So I will turn it over to you, Dr. Tate, and thank you very much.
All right, thanks, Julie. Let's see. Okay, are you all still seeing my presentation or my notes?
Presentation looks good.
Excellent. So as Julie said, I'm Channing Tate, and I'm an assistant professor here on campus with appointments in internal medicine and geriatric medicine. And you can see some of my other appointments on this slide. So I'm a mentored member of our cancer center. I work at Accords, and my lab is the Colorado Program of Patient-Centered Decisions, and we focus on creating patient-facing shared decision-making tools. Okay. There we go. So our agenda for today is I'm going to describe what shared decision-making is, give a brief overview of hospice care and disparities in hospice utilization. I'm going to describe the development of a hospice-specific patient decision aid that I created in my lab and give a summary of some of the research and future directions where I'm going with this work. But my hidden agenda is I'm very non-traditional, and this is not going to be your traditional academic talk. So this is going to be a lot about my journey as to how I got here and why I'm so passionate about this work. And over the next few minutes, you all are going to learn a lot about me and see a lot about the people who are very important to me and helped me get to where I am. So anyone who knows me knows that no matter what, every single presentation I give, I start with this slide. This is a photo of my mother, Sarah Pauline Davenport Tate. My mom grew up in inner city Cleveland, and she grew up at a time where the only opportunity she had in life was a high school education. So education was tremendously important to her, and she made a lot of sacrifices to ensure that me and my sisters had different opportunities in life than she had. This is a photo of my mother shortly before she passed away. So I lost my mother when I was in my early 20s to breast cancer. And this was my first direct experience with hospice when my mom passed away. When my mom died, I called her family in Ohio to let them know that she had passed away. And my mom's sister actually accused me of killing her. She said, "My sister was fine, and then you put her in hospice, and now she's dead." So, you know, the reality of this situation is that hospice did not kill my mother. Metastatic breast cancer killed my mother. And then, and even now, it's still unconscionable to me how anyone would think that a young woman in her 20s would want to do anything to hurt her mother. And more importantly, hospice really saved my family. Hospice gave us the tools to take care of our mother as she transitioned, but it also gave us the tools to take care of ourselves. This is a photo of my father. His name was Richard Dean Tate. My dad was a very, very big football jock. So he played football in junior high, high school. This photo is of him playing football at Kent State University. And then he went on to play football in the Army. And then he also went on to have 5 daughters who were unable to fulfill his legacy on the gridiron. This necklace that I'm wearing that you probably can't see on Zoom is actually a little brass football. So this necklace was given to me by one of my dad's sisters right before I defended my dissertation. She found it in a drawer doing some spring cleaning. And it's a little brass football, which says 1952 refrigerator bowl. So my dad played in the 1952 refrigerator bowl for Kent State, and this was a trinket that he got at that time. So it's a little football, and then there's a little white embossed refrigerator on it. So looking at photos of that game, all of the guys like ran through hollowed out 1950s refrigerators onto the field from the locker room. It was pretty cool. So I also lost my father. So this is a photograph of my father shortly before he passed away. And my dad had dementia, but he ultimately died of lung cancer. And to contrast the experience with my father's death with my mother's, my father's sister came to me and thanked me for how beautiful his death was. So my dad died in the home that I grew up with all of my sisters there, all of his siblings were there, a bunch of people who loved him were there to help support his transition. So it was a very big contrast to the experience that I had with my mother. And then later, that same sister, that same aunt, when she was ready to make her transition, she called me up and said, "Can you come do for me what you did for my brother?" And so I had the experience of spending a month with her, helping her transition, the gift, I should say, of doing that. So my parents didn't live long enough to see me earn a doctorate degree, but they very much inspire the work that I do. And I carry them with me in everything that I do, both personally and professionally, trying to live up to the legacy that they presented for us. So now I'm going to switch gears a little bit and talk about shared decision making. So this is a cartoon that I stole from one of my mentors and use in my talks just because it's kind of funny and it kind of boils it down into a digestible amount of information. But really, this is what shared decision making is. And I know that this is a very busy and complex figure, but I love this figure because it's the only one that I've seen that highlights trust as being important to this shared decision-making process. So this figure is actually developed by Monica Peak, who's an internist in Chicago. And what shared decision-making really is the process. It's the meeting of the experts. So you have the clinical team and the clinical staff who are the experts in the medical decision-making, the treatments, the diseases, and then you have the patient and their family and their loved ones who are the experts in what the patient needs, wants, and desires as they're making these decisions about medical treatment. And so the work that I do uses patient decision aids, and a patient decision aid is something that supports this process by informing patients about different disease and treatment options, and then helping them clarify their values on what's most important to them as they make this decision. So I'm going to talk a lot in a few slides about a hospice-specific patient decision aid that my lab developed to help facilitate that process. So for those in the audience who aren't as familiar as to what hospice is, this is a definition from the National Hospice and Palliative Care Organization. It defines hospice as the model for quality, compassionate care for people facing life-limiting illness. Hospice provides expert medical care, pain management, and emotional and spiritual support expressly tailored to the patient's needs and wishes. Support is also provided to the patient's family. So the graphic on this slide is a page that's in our decision-making tool. And so you'll see pictures of the decision-making tool as I go through this presentation. So just to touch briefly on the eligibility for hospice, and this is definitely an oversimplification, but generally, to be hospice eligible, you have to have a prognosis of less than 6 months or less to live. You have to be willing to forego curative treatments, and you have to be willing to see hospice clinicians. So those are the three general criteria for hospice eligibility. Medicare is the primary payer for hospice, and Medicare pays hospice services at a rate of 100%. So you've heard a little bit about me and my story, and you know that I'm very much pro-hospice, and I believe that there are a lot of benefits to hospice care. Some of those benefits are that hospice focuses on quality of life, not quantity of life. Hospice patients report better pain control, symptom management, emotional support, and better psychosocial outcomes. And additionally, there's a lot of evidence out there that people enrolled in hospice actually live longer than they would if they were receiving curative treatments. But it's also very important to note that hospice is not the right decision for everyone, and there are some drawbacks to hospice care that should be noted. Namely, accepting your own mortality and the fact that you have 6 months or so left to live can be very hard, painful, and challenging for people to accept. It can be hard to give up your care team, the people who've been taking care of you, to transition over to the hospice care teams. And a lot of times patients report feeling disappointed in themselves, that they're giving up, or that they feel like they're letting their family members down by accepting hospice care. So there are some drawbacks, and you kind of got to weigh the benefits and the risks. And this is a page from a decision tool that tries to do that for patients. Photo on this slide, one of my favorite photos, are of my two cousins. Miss Ruby in the red was 96 when this photo was taken, and Miss Cleo in the black was 98 when this photo was taken. So kind of what we know is that in general, hospice is underutilized. Roughly 1.7 million Americans use hospice annually, but there are some estimates out there that show that approximately 90 million Americans are currently living with some sort of life-limiting illness that might make them hospice eligible. This is important because, as I mentioned, Medicare is the primary payer for folks over the age of 65, and Medicare actually pays 84% of all hospice costs. But when we look at the Medicare data, we see that only about 51% of eligible Medicare decedents enroll in hospice. And when we break that down further and look at Black Americans, we see that only about 35.5% of eligible Black decedents use hospice care prior to death. This slide it's a pretty common figure in the hospice world. It just kind of describes the model of care of hospice and all of the different things that go into caring for the loved one and their family. So when we look at the data, we see that the median length of stay in hospice is 18 days, with 50% of those people receiving less than 18 days of care. About a third of all hospice recipients, so a third of that almost 2 million people, spend less than 7 days receiving care. And when we look at Black Americans, a third of Black Americans spend less than 3 days receiving hospice care. And this presents a few problems. One is the most expensive part of hospice is that initial enrollment visit where there's lots of paperwork and administrative costs. And hospice also provides medical equipment. So oftentimes people get hospital beds and other medical equipment delivered to their homes, and that's expensive. So these short compressed stays don't allow those costs to be defrayed over time. But probably more important to me is that those short stays don't allow for patients and families to take full advantage to all of these wonderful things that hospice provides. So just drilling down into the costs a little bit, this slide shows the difference between costs for people who are not receiving hospice in the lighter colored bars and people who are receiving hospice care in the darker colored bars. So you can see over time, those cost savings are exponential. And there are some figures out there that state that if we could enroll more people who are eligible in hospice sooner than those last 7 days of life, Medicare could save almost $2 billion annually. It's also important to increase hospice use. I'm sure you all have heard terms like the graying of America or the silver tsunami. The fact of the matter is that we're aging as a society. So right now, there are approximately 58 million Americans over the age of 65, and that's projected to be 95 million by the year 2060, with 20 million of those folks being over the age of 85. This trend is mostly being driven by the baby boomers who currently are reaching Medicare eligibility by a rate of 10,000 per day, and that trend is expected to persist for the next couple years. And there's this perception that baby boomers are young, hip, healthy, active, and sorry, boomers on the call, that's just not true. When we look at the data, the boomers are the sickest generation and they utilize more healthcare services than any other generation previous. When we drill down and look at this by race, we see that the number of BIPOC individuals reaching the age of 65 is outpacing that of white Americans by 4 to 6%. So currently about 5 million Blacks are over the age of 65, but that's going to be 12 million by the year 2060. So it's important to increase the use of hospice because most people in hospice are over the age of 65, and we're in this time in society right now where our society is getting older and more racially diverse. So looking at some disparities in hospice care. So this slide shows the percent of the US population versus the number of people utilizing hospice services. So at the bottom, we see the red bar. The percent of white Americans in the US right now is about 76%. And of that 1.7 million hospice users, 82% of them are white. If we look at Black Americans, about 14% of America is Black, but only 8% of Black Americans, or 8% of that 1.7 million are hospice users, or 1.7 of, sorry, 8% of the 1.7 hospice users are Black. And then you can see that there are some other striking race and ethnic disparities in other groups too. When we look at this in terms of the top 3 diagnoses for hospice users, which are cancer, dementia, and heart disease, we also see these disparities. So a Black American is much more likely to be diagnosed with a more severe, more aggressive, harder to treat forms of cancer, and are much more likely to die of cancer than their white counterparts. Heart disease accounts for about 30% or a third of deaths in Black Americans, but about 23% of deaths in white Americans. And it doesn't really look like there's a disparity there with dementia in the middle, but that purple bar is going to far exceed that blue bar soon. So currently 96% of all people with dementia are over the age of 65. And we know that age is the greatest risk factor for developing dementia. So when we drill down into this a little bit more, we see that currently 19% of Blacks over the age of 65 have dementia, and 10% of whites over the age of 65 have dementia. So as we get older and more racially diverse, that purple bar is going to far exceed that blue bar. So that's kind of the background of the disparity in hospice care and shared decision-making. So now I'm going to talk a little bit about the research. So a few years ago, the National Academies of Science, and you don't need to read this slide, I'm going to summarize it, formerly the Institute of Medicine, put out this call and said, we are doing a terrible job supporting people at the end of life, especially in communities of color. We've got to do better. And at about the same time, the NIH put out a call and said, yeah, they're right. We're doing a terrible job of supporting people at the end of life, and we need more research and more evidence-based interventions and shared decision-making, especially in communities of color, to ease this burden and disparity. So that's the background. So now what? So this slide has some photographs of my graduation when I earned my doctorate. The big picture in the middle is a photo of me and a couple of my sisters. So I have a lot of older sisters. I'm the baby in my family, and I graduated in the pandemic. So not everybody was able to attend my graduation, just the 2 sisters mentioned there. And so my big sisters are my heart, my life, and my support. They support me in everything I do, but they also have absolutely no idea what it is I do for a living, and I can't explain it to them. So I actually invited them to come to this talk. So I think that a couple of my sisters are on this call. So if they're here, hey sisters. And the last thing I'll say about that is, you know, being the youngest, for the youngest out there in the room, we like to tease our older siblings quite a bit. And so I always joked around and said that once I became Dr. Tate, the only people required to call me Dr. Tate were going to be my 3 older sisters. And of course, you can imagine that they were not at all amused by that. And so they've taken to calling me Dr. Baby Sister, or DBS for short, is what they now call me. So now I'm going to switch gears and talk about my journey in research and how I got to be here with my research. So hearkening back to that experience that I had with my mother, trying to understand why people view hospice so negatively. So one of the very first studies that I did was called Hospice She Yelped. And what we tried to do in this study was understand what shared decision-making tools were out there to support people as they were making this decision to enter hospice care. And so we did an environmental scan of all freely available decision aids. We reviewed about 130 decision aids and found only 7 that mentioned hospice tangentially, but hospice was not the actual primary decision being made. So then we started to wonder, well, how do people figure out what they need to know about hospice? So what we did to answer this question was we brought 20 lay people, 18 and up, I think the oldest person was in their 60s or 70s, into our office, gave them a little vignette that said, you just found out a loved one needs hospice care. How would you find out information? We sat them down at computers, and then we actually tracked where they went online to find out information about hospice care. And then we did some exit interviews with them to find out where they went and why. And we were completely shocked, stunned, and surprised to find that every single one of them went to Yelp to find information. And when we asked why, they said that they didn't trust the information on government websites or individual hospice websites as being accurate and unbiased. They felt that they were being sold a product. And they really felt that Yelp was the place where they were going to find the most accurate and unbiased information about what hospice is and what hospice isn't. So, of course, this led us to want to understand what people are saying in these one-star reviews. So we did another study where we analyzed the negative online reviews of hospice agencies just to understand what it is people are saying in these reviews. So what we tried to do is identify 100 hospices nationwide. We wanted one for-profit hospice and one nonprofit hospice in each state. So we tried to identify 100. And then we chose 200 patient visits per year just because we wanted the hospice to be big enough to have a online presence. So when all was said and done, what we were able to do was identify 67 unique hospices nationally with 137 unique one-star reviews. And when we read those reviews and analyzed them, we found the criticisms really just kind of boiled down into two big buckets. Things that we thought were actionable that the hospices might be able to modify and provide better care, and things that were unactionable. So things that were kind of outside the purview of what a hospice agency could do. So if you look at this, the actionable things really center around communication, discordant expectations, promises being made, not being kept, confusion about eligibility, poor communication over who's coming to the house and when, scheduling visits. There's this misconception that hospice is 24-hour care in your home, which it's not. So we thought these actionable things were things that could be modified with better communication. The unactionable things were bigger, broader social issues like misperceptions of hospice, misalignments of goals, being sold a product, not medical care, and a lot about what the meaning of a good death is. And that is so personal and individualized that it's just impossible to have a gold standard definition of what a meaning of a good death is. So once we did this and we understood kind of what was out there in Yelp, we decided to start thinking about developing our own decision-making tool. So the next study we did, it's like a death sentence, but it really isn't, what patients and families want to know about hospice care when making this decision. So for this project, what we did was we did a series of focus groups with family members who had taken care of a hospice patient, hospice workers, so nurses, chaplains, social workers, volunteers. And then we did a few semi-structured interviews with individuals who are enrolled in hospice, but were just too sick to come into our office for a focus group. So in this study, we just generally asked the question, what is it that you wish you would have known before you made this decision to enroll in hospice care? And what that boiled down to was 4 key points. People wanted to know, what is it, why they need it, where they get it, and how do they pay for it? So I'm going to share some of the data that we collected in this study and what people said about these things. So under that decisional domain, what is it? We had a caregiver say, I mean, I didn't even really know what hospice was. And so it was kind of a scary thought. It's like a death sentence, but it really isn't. You know, it's more of making your life comfortable while you're here. A volunteer coordinator said, hospice is a holistic philosophy. It's not just medical care. You're going to care for the patient and their family the whole way through. Under our domain, why do they need it? A caregiver said, the notion that I think people feel like choosing hospice means giving up hope or quitting. And that's something they either don't want to do or they don't want to disappoint their family that way. Instead of hospice means giving up hope, hospice means accepting help. Another caregiver said, hospice is an invaluable service for the caregiver. Again, the patient's going to be taken care of, but the caregiver is the one that needs help since nobody knows what caregiving is until they've been in those shoes. Nobody. Under our decisional domain, where do I get it? A caregiver said, it's a team that goes wherever you live. You don't have to move. It doesn't automatically mean you're going to die right away. That's what I assumed when it was first mentioned to me. And then finally, under that cost decision, a nurse said to us, how much is this going to cost me? That's the first thing. How much is this going to cost me? $25, $50? I don't got that kind of money. They just go there. So I think that it's huge. It's finances. Anytime, it's always about finances. So now that we knew what this decision aid needed to say, what is it, where is it, why do I need it, how do I get it, how do I pay for it, we went on to develop our decision-making tool. So the next study was the development of this patient decision aid. And the way that we went about doing this, we used this 8-step process, starting with the needs assessment. So I've already talked a lot about what we did here, the Hospice Yelp study, the focus groups, we reviewed the evidence, and then we used some decision-making theory. So what we did is we drafted something on paper, framed around those 4 decision questions, went back to our key informants and our community members and said, what do you think? They said, this is awful, redo it. So we redid it, and we went through that iterative process of revising and incorporating feedback 10 times before we landed on our final decision-making tool. And the product that we ended up with was a 12-page booklet and about a 17-minute video. So in my lab, our decision-making tools always have a booklet and a video. We like to have a booklet so that the patient has something they can touch, they can feel, they can write on, they can take to their clinical appointment and have and hold and talk about these decisions with their clinical team. But we also do videos, and our videos incorporate actual patients that got the decision or got the treatment or did not get the treatment and why. It's very important in shared decision making that you make neutral and unbiased tools that don't sway people one way or the other, but provide the information so that they can make the decision that's right for them. Developing this tool was also very challenging because most of our decisions are treatment, yes, no, surgery, yes, no. But hospice isn't really a yes, no decision in a lot of cases. It's a when is the right time for hospice. So we were very cognizant of that when we tried to build this tool. And also, there is a big dissonance between the language that clinicians wanted us to use and the language that patients wanted us to use. And so we erred on the side of the patient because this tool is really about helping the patient understand hospice and having that conversation with their care team. So once I had this tool developed, then I was able to really circle back and drill down into why hospice is so stigmatized in the Black community. So the photo on this slide, that's a screenshot of the opening to the video tool. So when you read the literature says a lot about how hospice is underutilized by communities of color, Black specifically, because of religion, culture, and other things. I don't necessarily think that that's true. I think hospice is underutilized because people don't understand what hospice care is. So there are disparities in knowledge about hospice care, which leads to poor opinions about hospice care, which leads to misconceptions about hospice care, which leads to underuse of hospice care. So for this study, my overall research question was, do hospice decisional support materials help improve hospice knowledge, opinions of hospice, and decision self-efficacy, which is a measure of how confident one feels they can make a decision that's right for themselves and older Black Americans? The photo on this slide is my Aunt Ellen cradling her great-granddaughter. So this study was a small randomized controlled trial using myth methods. The primary outcomes were 3 surveys: hospice knowledge, opinions of hospice, and decision self-efficacy, which again is a measure of how confident one feels that they can make a decision. And then we also gave everybody a blank piece of paper and said, in your own words, please describe what hospice care is. The study was very, very unique in that it was 100% community-based recruitment. So there was nothing tied to a clinical appointment to be in this study. And so how I recruited was I went to churches, community center, retirement communities, anywhere a participant or a community member asked me to show up, I showed up. And so the photo on this slide is at an event where I was able to recruit 55 older Black adults in one day at a local Black church here. And the thing that I really want to highlight about this event in this slide is that we were very intentional on how we planned this. So this event was planned on Food Bank Day, so people could come and get their food bank allotment. We provided lunch. We provided transportation for anyone who wanted to attend but couldn't. We had someone there who was talking about gardening and helping people start their gardens. This was done in the spring. There was someone there doing diabetes education. There was somebody there doing high blood pressure checks. So my point is, this was a community event that I was very fortunate that my research got to be part of, but it was not an event about my research. So again, research methods, the intervention, I talked a lot about how we developed that intervention, the hospice-specific patient decision aid, 12-page booklet, 17-minute video. These are some screenshots of the video, and you can see there one of the patients who's in the video talking about her experience with her father. These are a few screenshots of the paper tool. And so this is the flow diagram for how this study worked. So to be eligible to participate in the study, you have to self-identify as Black or African American and be at least 65 years of age. And I intentionally chose that 65-year age cutoff because of the Medicare issue. I didn't want people worrying about how they were going to pay for hospice services because Medicare pays 100% of hospice services for Medicare beneficiaries. It's a right due to you as a Medicare beneficiary. So at baseline, we asked everybody to do the hospice knowledge survey, the hospice beliefs and attitude scale, which measures opinions of hospice, decision self-efficacy, again, how confident you feel you can make that decision. And then that qualitative piece where we gave them a piece of paper and said, describe hospice in your own words. After they did those baseline assessments, people were randomized to the intervention where they received the decision aid or the control where they did not receive the decision aid. And then a month later, we followed up with everybody on those three quantitative scales. At the end of the study, everybody in the control was mailed the decision aid. So at the end of the study, all 144 participants got the decision-making materials. So now I'm going to talk about the results. So this is a pretty standard table one that you see in research. And I'm not sure if you can see it on Zoom, but I've highlighted or bolded some of the things on here. So in the literature, we often see the extremely poor and the extremely rich, and the disparity between those two groups. But what's unique and special about this study that I did is that I managed to recruit an incredibly middle-class sample of older Black adults. And we don't see a lot in literature about middle class. So the things that I've bolded on here, about 40% of my respondents reported having a college degree and 75% reported having at least some college. When you look at national data for older adults, Black adults over the age of 65, 29% report having a bachelor's degree or a four-year degree, and 33% report having some college. When we look at income, the national median income for a Black adult over the age of 65 is $50,000 or less. But in this cohort, 40% of the respondents had an income of $50,000 or $50,000 a year or more. So again, a very middle class and unique and special sample. So main outcomes. So one of the main outcomes was this hospice knowledge test. So this is a scale that went from 0, no knowledge, to 23, complete knowledge. So you can see in this cohort, knowledge was actually pretty high in both groups. It went up slightly, but this was not statistically significant. The hospice beliefs and attitude scale measures opinions of hospice. So lower numbers, 8 is the minimum, are poor opinions of hospice, up to 40, which are favorable opinions of hospice. About the same at baseline in both groups. Again, it went up slightly in both groups, but not statistically significant. So this decision self-efficacy scale that goes from 0, no self-efficacy, to 100, complete self-efficacy, was a little bit different. And so at baseline in the control, it was 73, and then it went up a little bit. In the intervention, it was 79, and it went up quite a bit to 90, but again, it was not statistically significant. So the reason that I think that overall this was a negative study was because of how I recruited. So I mentioned that I did community-based recruitment. So I went into the community and recruited. And I randomized people at the individual level, which I think was the problem, because I heard stories of watch parties of the decision aid video at some of the retirement communities that I went to. I've shared with you how important my sisters are to me. I've recruited a group of sisters in the study, and I wonder if the sister in the intervention showed the intervention to the sisters in the control. And so I think it had a lot of spillover effects, which is why we saw things go up in both groups and why it wasn't overall statistically significant. But there was something unmeasurable about looking at this decision aid materials that really empowered people to be able to make this decision that's right for them. So now I'm going to talk a little bit about some of that qualitative data that we collected. So one of the big things that came up when we analyzed those writing samples was this idea of place. So on this slide, the quote says, hospice care is a facility or place where a loved one is taken to receive final care. Another person said, hospice care, I think, is transferring healthcare to a nursing home, getting you comfortable and emotionally ready. And another person said, hospice is a place, center, nursing home, or hospital where elderly people are unable to care for themselves and close to death. a place that makes you comfortable as possible in your last days, a place where family members place you when they can no longer take care of you. So this was very interesting to me. So as a Black American, it makes sense to me that if people think that hospice is a physical location where you institutionalize your loved ones, they don't want to do it. Institutionalizing your loved ones is something that's highly stigmatized in the Black community. So it makes sense to me that if people think that, they're not going to want to enroll in hospice care. I think the most fascinating thing that came from this study were some of the myths and conspiracies that emerged about hospice care. So I had one respondent saying, my opinion is that they give comfort care to kill you or drug you to death. I'm a nurse, so I know. They give you morphine in hospice, and all Black folk are allergic to morphine. They kill us. Hospice is a nice way of putting someone to death, even when they want to have a natural death. In my opinion, hospice was created by the KKK so they could legally kill Black people. Some people, even less educated than me, look at hospice the same way as a nursing home. Don't do it to anyone in your family if you love them. So this data really helped frame my thinking around this, and I kind of think about it as a stoplight. So you have the green, where the people who are just going to enroll in hospice and do well. The yellow are those people who think that hospice is a physical place. Like, we can do some education and some interventions to explain what hospice is and isn't with them. But there are some people, like the woman who thinks that hospice was created by the KKK, that no matter what we do, we're just not going to be able to reach her or change her epistemological view. Real quick, since I mentioned how important it is to create neutral and imbalanced tools, we did ask about that in this study. So the take home from this slide is that about 93% of respondents thought the stories from actual patients were good or excellent. 94% of respondents thought how we described where you get hospice services was good or excellent. 96% of people thought that we described the services provided by hospice was good or excellent. 89% thought how we describe how hospice is paid for through insurance was good and excellent. 89% thought how we described what palliative care is was good or excellent. And 100% of people thought that how we describe what hospice care is was good or excellent. I mentioned in shared decision-making, you want to make sure you have a neutral and balanced tool. So we asked about that. So the take home here is about 81% of people thought the tool was balanced and not slanted towards enrolling in hospice or not enrolling in hospice. About 97% of people thought the amount of information we provided was just right. And 97% of people thought that the length of the presentation was just right. So not too long or not too short. And then we wanted to know if people would think that this tool was useful. So we asked that question too. So we asked if we included enough information to help you make a decision about hospice care, and 97% of respondents said that we did. And then we asked if you would find that decision-making tool helpful if you were making a decision about hospice care, and 100% of respondents said that they would. So just to sum up, my current work now, so that study that I presented was largely negative, but I'm very lucky that I got funding to replicate that study in a nationally representative sample of older Black adults. So I collected data on 403 Black adults nationally on the hospice knowledge, the opinions, the decision self-efficacy, the trust in healthcare, to see if that moderates any of these relationships. And then we also did that writing sample with this cohort of 400. And we also did some qualitative interviews with about 20 or so of these respondents to further drill deeper into this issue. So we just finished collecting that data. We're analyzing it. Preliminarily, it looks pretty much the same as what I showed you, where there is an effect on knowledge and opinions. And I hope that maybe next year you guys will invite me back and I can share the results of that study. And then lastly, I've been very intentional in doing all of my work in healthy Black adults up to this point. And the reason for that is I don't want people to find out and hear about hospice the first time when you've just found out that your loved one is actively transitioning and you're already emotional and confused. So I've always done this work in healthy adults so that people know what hospice is and understand what hospice is. So when they're in those times of crises, they can make the decision that's right for them. But my next study is going to be moving that a little bit further upstream. So I'm writing a K-level peer development award where we're going to use this tool in the outpatient palliative care setting. So a big component of that study is going to be convening a group of Black patients and providers and clinicians in the outpatient palliative care clinic here at the university, and having them tell me, A, is this decision aid right for use in this context and in this setting? Do we need to modify it or adapt it? And then have them help me understand the best way to deliver this tool in the palliative care clinic. Do we do it at that initial enrollment visit? Is it delivered, when somebody decides to stop chemotherapy or dialysis? Who is the person who delivers it? Is it the doctor, the social worker? All of those things I'm going to have these people tell me, and then we're going to pilot test it and see how it goes. So that is all I have. These last couple of photos on this slide are a picture of my parents before they got married, and a picture of them over here on a New Year's Eve where they were quite tipsy and quite happy, and I just love that photo of them. I'm happy to try to answer any questions. This is the website for my lab where all of our decision-making tools are available for free, and then hopefully this QR code will take you to our lab's website too. So thank you.
Thank you very, very much, Dr. Tate. Really appreciate what a great presentation. I have a question to start us off, which is the question of trust. And you mentioned that early on in the decision-making, and then did a really good job presenting the material that you, and the study that you did. But the one slide that actually, where there are quotes from people who, very basically, underneath a lot of what people had to say, perhaps was cultural, like giving Blacks morphine, and everyone knows they're allergic to morphine, those kinds of things. Seems to me that there is an underlying trust issue that's really significant that impacts people's viewpoints. And I was wondering if you might speak a little bit about how to engage trust and mistrust there from what people were saying.
Sure. So I actually have done a lot of work around this issue in the Black community, and I actually teach classes to med students about this very issue. And what I tell those med students is you kind of need to understand that things like Tuskegee, Henrietta Lacks, those things, civil rights, Jim Crow, those things are in the living memory of our older adults. They live through those things. That's not history to them. And so when you're engaging with these folks, they just want you to acknowledge that they live through this horrific trauma perpetrated on them by this country, and just try to understand where they're coming from. Like one of my participants said something to the effect of, I just want my doctor to understand what it's like to be a 75-year-old Black woman who grew up in Mississippi. And so I tell people to kind of build trust, all you need to do is say, what was it like for you growing up in Mississippi? And try to meet them on a person and human level to try to break down those barriers and build trust. Nobody in hospice wants to hurt anybody. That's not what hospice care is about. And so having those conversations, and I hope this decision-making tool is something that can help facilitate those conversations, I think will do a lot to help build trust in those relationships.
Thank you. I have a question. Someone did make a comment about being in a rural area, seeing patients decline hospice. Do you know if there is a difference between more rural and more urban, or have you looked at that in terms of understanding and being offered hospice, having hospice available, people declining for various reasons?
Yeah, that is a really, really good question. So thank you for asking that. And there is a difference. And part of it is that rural areas are just under-resourced. And so a lot of this care is delivered via telehealth, which also is under-resourced in rural areas that where people don't have access to high-speed internet and things. And so that's actually one of the things that we're looking at in that larger study that I mentioned, where we collected data on 400, we're going to be able to really drill down into different regions and see what resources are available and how those resources are being offered to patients. And with those qualitative interviews, which we haven't had a chance to analyze yet, we really drilled down into rural areas, why you declined or why you accepted. And a lot of it really just boils down to these access issues.
Great, thank you. A question, in what ways do disparities impact the underutilization of hospice care by older African Americans?
In every way possible. That's the short answer. So, you know, like we talked about with trust, lots of people of color don't trust healthcare. Lots of people of color often are delayed in getting these diagnoses. There's some evidence out there in the literature where a lot of people of color think hospice is substandard care. So there's this barrier and this disconnect of not getting the most aggressive treatments, but also wanting to have a death at home. And so I think that there's a lot of opportunity for us as researchers and clinicians to really get into community and unpack those things in different communities and help explain that hospice is not substandard care, but it is a choice that you're making to not receive care. So disparities and differences and distrust affects everything.
Right. And with that, someone wrote, such an interesting presentation. How do you change negative perceptions so tightly held? And know that it happens over time. How do you discuss it early in healthcare?
I love that comment. And this is something I get asked a lot, and my answer people don't like. This takes time. So what I presented was over 10 years of work. Before I was able to do that study where I recruited 144 people, I spent 3 years going to community events, just showing my face, showing up, being present, talking about these things, trying to provide the most accurate information that I can, providing resources to people if I couldn't answer the question. And so it takes a very long time sometimes to build up trust, especially at the University of Colorado, where there are a lot of issues with how this institution has treated people of color in this community and trying to rebuild trust in the community. It just takes time and persistence.
There are a number of comments also that talk about the building trust and introducing it early in the context of respect, of being respectful between providers and any patient, and the way that they're treated generally with respect and information. Somebody did also wonder, hearing the perspectives about distrust, I wonder if a myth versus fact infographic would be helpful.
So I encourage you to go look at the tool, because there actually is a page of myths and facts in the decision-making tool.
So a very insightful presentation based on your experiences in tapping into community connection to recruit participants into your pilot study. What advice would you give to other health equity researchers to recruit hard to reach communities of underserved and color?
So the biggest piece of advice that I can give you, I don't do a study where I don't have community members helping me design the study. We need to get out of this model where we have these great ideas and then we go into these communities and say, this is what we're going to do, because that might not be the priority of that community or what they need. So I encourage you I have one community advocate that's so strong, to bring those people to the table and just listen to them and just hear them and incorporate them in the whole process of doing our research. There was a second part of that question that I missed. Will you repeat it, please?
Just what advice would you give to other health equity researchers to recruit hard to reach communities of underserved and color?
Yeah, and then again, just keep showing up. There's so much fear and distrust. Like I tell med students that don't ever say non-compliant. That is not a word. You need to understand that people of color in this country, most of them did not have healthcare until they turned 65 and got Medicare. So they're not used to dealing with people in this way. So you just have to be persistent and keep showing up and keep being authentic. And eventually you'll build trust. And now I have this very robust community network that people want to tap into. But I'm also very, very conscious of not letting people just go into this community without it being mutually beneficial. So if you come to me and you say, I want to go to Zion Baptist Church and do X, then I'm going to say to you, what is it you're going to do at Zion Baptist Church? How are you going to help that community? How are you going to give back? So these relationships need to be reciprocal. If we're going to go and take, we need to make sure that we give back, which is why at that community event that I did, we had transportation, we had blood pressure checks, we had diabetes education, because that's what the community members told me they wanted to have at that event.
Wonderful. You know, I was struck also by your emphasizing the point that this was an event that at the church. This was an event that had a series of things. It wasn't just an event for this, which also would attract or not different groups of people. So
absolutely.
Someone also wrote, I value your own personal experience you had with your family regarding hospice that you shared with your mom and your dad. Do you feel there's a benefit to introducing palliative care or see any difference in the response you get from people you've worked with? Maybe people who confuse palliative care with hospice care, which is sort of another layer of this in terms of the understanding.
Yeah, I was wondering if somebody was going to point that out. So those of you who are familiar working in this space, you'll note that Venn diagram that I had with the bubbles was actually not accurate. So we had overlapping bubbles of hospice and palliative care, but the way that should look is a big circle with palliative care, and then within that big circle is hospice. But what we found in talking to patients is they didn't understand that model, and they liked it kind of being separated out in the way that we depicted it in the tool. And so I think you're absolutely right that people don't understand what palliative care is either, and they don't understand that there's a kind of a difference between palliative care and hospice. Hospice is really for people near the end of life, but palliative care really is to support people in much the same way who have chronic disease. So you don't have to give up your curative treatments to receive all of the benefits and support of palliative care. The volunteer services, the chaplain services, the social work services, the better pain management and control. And so that is definitely an area that I need to do better in, is really explaining the differences between palliative care and hospice and how those things work together. I think our palliative care team here, anybody who works in that clinic on the call, thank you. You guys do an amazing job at explaining that to people and providing care.
Great. Okay, here's one for you. Do you see patients in clinic?
No, I'm 100% a researcher. 100% a researcher.
Though, if someone asked you to come in and talk about some of these things with folks, do you do that?
Absolutely, I would be willing to do that. And I'm really hoping that will happen with that next study, where we're moving this work into the palliative care clinics, where we can start engaging in some of these conversations.
Okay, are there structural interventions that you think might support this work? I ask because I feel there's a lot of effort that goes into helping distinguish between hospice and palliative care, as well as explaining hospice as an insurance benefit. What as a community should we be advocating for through policy work and advocacy, while we also work on supporting individuals making decisions?
That's a whole another hour-long topic. I think one of the biggest structural barriers is how the Medicaid hospice benefit is structured by Medicare. And they've been talking about changing this for 20 years, and it still hasn't changed. One of the biggest barriers just globally, no matter what you look like, is that 6-month criterion. Because that's hard for people to acknowledge and digest, that I have 6 months left to live. And then there's a lot of confusion about what happens if you're still alive after 6 months. They don't kick you out of hospice. You have this recertification project. One of the One of the gentlemen who was part of this study, his wife was on hospice for almost 4 years. And so there are big, larger systemic structural issues that we have to address. What we can do at a local level is just be that advocate and try to explain this the best way we can to our community members. Denver is a place where there are a lot of different hospices and a lot of different choices. So one thing that I think is important is there's a hospice nurse described this to me as the big H, which is the hospice Medicare benefit. But then there's also the little h, which are the unique individual hospices that offer different services depending on what their resources are. So helping people understand that difference too, I think is very important.
Okay, great. Another question, could you talk about the beginning? How did you identify community members who helped you learn what the community wanted?
Yeah. So like I said, anytime a community member asked me to go somewhere, I went. So I went to church picnics, I went to health fairs, I went to community picnics. Anywhere anybody asked me to go, I went, and I brought my materials and I talked about this work. And then I would hear their stories about what happened to them or their loved one. And they got interested and wanted to engage and wanted to be part of the study. It takes a lot of boots on the ground, nights and weekends work. And that's just the reality. People want a quick fix, but the reality is this work is hard.
Wonderful. I think maybe the last comment or question, are the data and research materials you presented available to folks beyond University of Colorado and AMC?
Yeah, I mean, this is another problem with science. So we've published all of this data of what I presented. So, I'm happy to circulate the publications, but I think the more important thing is doing talks like this and hearing from you all and having you all contact me and having those conversations and spreading and disseminating this out widely in our community networks. And like you said, this talk will be on the website, on the ethics website too.
Wonderful.
And
well, there are many comments in the chat that this was an incredible talk and very helpful.
Please,
so.
I'm happy and eager to talk with you all. So if you have a question that I didn't answer, just please hit me up. I'm happy to talk to you all. Thank you for coming.
Marvelous. Well, great to have you. And again, thank you very much, everyone, for your comments and your questions. And Dr. Tate is available, as she said, if you need to have further conversation with her. I want to remind you that our next ethics grand rounds will be in May 9th at this noontime, and we'll be focusing more on artificial intelligence. So thank you very much again. Appreciate that. And if you want a recording, it will be available, I think, later today on the Center for Bioethics website. Thanks. Bye-bye.